have questions, please add them to the Q&A box, and we'll either respond to them at the end in a Q&A session where I'll relay your questions as best I can, or there will be asynchronous responses added as possible. All right, Kathryn, take it away.
Thank you so much for the introduction. I am also so grateful to get to work with you, but I guess we can chat about that another time. I'm not able to see folks' faces, but before I jump in, I just want to say today is a really hard day for a lot of people in the room. And so yeah, I know that I'm talking about in some ways a hard topic on a hard, stressful day, and just know that I'm very aware of it as well and doing my best to employ super effective distraction as my primary coping strategy. And maybe this hour will work for that for you. But if you need to step out at any point or check your phones or anything like that, please, I mean, I can't see you, so obviously feel free to do so, but especially today, feel free to do so. Okay, so as many of you are likely aware, suicide is a leading cause of death worldwide, with about 800,000 people dying by suicide each year. Non-fatal self-harming behaviors are even more common, with an estimated 16 million people attempting suicide each year and over 150 million people thinking about suicide. In other words, these are a major health problem affecting millions of people globally each year. And although rates vary by age, it's actually a major health problem affecting people across the lifespan. And a lot of people are unfamiliar with the fact that this is something that also impacts youth. In fact, suicide is the third leading cause of death among youth ages 10 to 18. And recognizing the severity and urgency of these problems, there's been huge increases in suicide research over the past several decades, with similar increases in research on youth in particular, who used to be much less studied in this area. And yet, unfortunately, our treatments are just not doing a great job of reducing fatal or non-fatal suicidal thoughts and behaviors. And unfortunately, our treatment effects haven't actually gotten any stronger over the past 50 years, with effect sizes looking even more disappointing for youth specifically. And paralleling this slow progress, the suicide rate also hasn't declined appreciably over time. There are some small fluctuations up and down, but when we look over the past 50 to 60 years, the suicide rate today looks really similar to what it did in the 1960s. And so to me, this suggests that we're probably missing something and that maybe there are some key assumptions about these phenomena that just aren't quite right. And so a lot of our research and treatments are missing the mark because we're missing important pieces of this puzzle. And I'd like to believe that my research focuses on several pieces that we might be missing, but for today, I primarily want to shine a light on two critical pieces of this puzzle. So for the majority of my talk today, I'll be chatting about access to evidence-based and suicide prevention care for youth. And then towards the end, I'll chat about some gaps in parent and guardian knowledge about how to support youth experiencing suicidal thoughts and behaviors. So, as you're all probably very well aware, given so many of the people in this group, most adolescents experiencing mental health challenges don't access mental health specific services. And this is also true among suicidal youth. Just about 1/3 of those youth experiencing suicide ideation in the past year report engagement with a mental health provider over the same period. And unfortunately, things don't look much better for those experiencing more severe suicidal presentations. In fact, fewer than half of those with a suicide plan or attempt in the past year report past year engagement with a mental health specialist. And a big reason for this low uptick in care is that there are major barriers keeping teens from accessing mental health care in general, and especially from suicidal thoughts and behaviors. And I'd like to argue that suicidal youth face extra treatment barriers. So first, they face the barriers that all people face that limit both access and desire to pursue mental health care. Things like ability to access it, like stigma, cost, transportation, awareness, and these major provider shortages that are particularly relevant for youth. They also face barriers that tend to reduce engagement with suicide-specific services, like fear of hospitalization and breach confidentiality, as well as additional shame and stigma around suicidal thoughts and behaviors. And then on top of these, there are also youth-specific barriers, including guardian consent requirements, inconsistent and confusing practices in sharing therapy content with parents and guardians, and an enduring fear of worrying parents and guardians, or that parents and guardians won't know how to respond. And related to each of these barriers, I just want to pause here and share that I'm so regularly hearing about these barriers for youth. It's particularly on my mind right now because I'm teaching an undergraduate course, Introduction to Clinical Psychology. And several times across the quarter so far, we've circled back to personal experiences with our students avoiding disclosures of suicidal thoughts and behaviors to trusted adults and healthcare providers because of fear of repercussions. Many of them have highlighted that growing up in middle school and high school, they heard horror stories of minor disclosures of passive suicide ideation leading to ER visits and hospitalizations that weren't anticipated, leading to this broad and general feeling that it's not clear what they can safely share without a major reaction, even from providers who say that they'll only break confidentiality if they're worried about your safety right now. In other words, these aren't theoretical barriers. They're major barriers preventing youth and really adults in need from seeking help and disclosing to providers. I know that as a field, our primary goal is to help youth and prevent suicide, but I so often worry that our standard practices are sometimes doing the opposite. I know that's a talk for another day, but I think before chatting about some of my work that just involves youth, it's just so important to chat about this directly. Okay, so coming back to where I was before, for myriad reasons, so many suicidal youth in need of mental health care aren't accessing it right now. And to fill this critical gap, I think we have to consider some alternative treatment approaches, including those that provide treatments to teens directly in spaces they know how to access and feel safe pursuing. And I'm guessing I don't have to convince this particular audience, given the topic of the series, but I believe that digital interventions are among the best ways to do this. So we know that most teens in the US report that they either own or have access to a smartphone and or the internet, and nearly half say that they're online constantly. In other words, I think that if we're creatively designing treatments that can capitalize on this heavy use of smartphones and the internet, we might be able to increase access to psychiatric care and suicide prevention care for youth. And so my collaborative research, including several folks in here today, and especially Jessica Schleider, have taken several approaches to providing youth with digital interventions. And today, I want to specifically focus on a digital self-guided safety planning intervention. So before I talk about our adaptation, the safety planning intervention is a brief 5 to 10-minute single session intervention shown to significantly reduce suicidal thoughts and behaviors in adults. Jessica actually made a poll. I'm just kind of unfamiliar with exactly who's in here today. So I'm wondering if folks would be willing to fill out the poll to let me know if you're familiar with traditional suicide safety plans. I wanted to vote myself, but I'm not able to vote. And Jessica, I can't see the results of the poll. Are you able to see it?
Yes, 66% say yes,
Okay.
15% say no, 18% say ish.
Okay, awesome. I'm glad to hear that a lot of folks in here are familiar with this to a degree. But for those who are less familiar, I do want to share that. Oh, now I see it. Thank you. So I do want to share that in a safety planning intervention, people at risk for suicide typically work with a trained provider, and they receive brief psychoeducation about suicidal thoughts and crises before developing a personalized one-page plan, like the one pictured here, with skills and resources to use during future suicide crises when it's really difficult to think clearly. And you'll notice on this safety plan here all of the traditional steps that are included. I will say sometimes folks include an additional step about basically things that people are looking forward to in the future, things that bring them joy, etc. And for reasons that I'm happy to chat about if folks are interested, that's not something that I've included in the safety plan here. But broadly, there's strong evidence across several randomized controlled trials that safety planning interventions can reduce suicidal behaviors in adults compared to those who receive treatment as usual. And this is actually a really widespread intervention across outpatient and acute clinical settings across ages. But I will say we don't have adequately powered randomized controlled trials testing this intervention in teens and youth specifically, regardless of the format. That said, we do have a lot of encouraging evidence that safety plans can be used with teens, that they like them, and that to some degree they use them after creating them. And that also adults can complete these plans alone without a clinician. And so, building off of this preliminary evidence, and knowing that this is already a commonly used tool for suicide prevention in youth, our team created a self guided electronic version of this intervention within Qualtrics, specifically directed at youth. And our self-guided electronic safety plan broke down each of the steps of a traditional safety plan, and we just added language to clarify the purpose of the safety plan, as well as how to complete each individual step. And then to maximize engagement, we tried to add images and short text whenever possible. Unlike traditional safety plans, our adapted versions don't require a trained clinician to administer these. And theoretically, a teen could complete the safety plan anywhere they have internet access. And then another key component here is that parents and guardians aren't inherently involved. These are things that we are having teens complete on their own. In traditional safety planning environments, usually clinicians are inviting parents and guardians into the conversation, either to support youth in the creation or enactment of these plans. And there's a lot of reason to believe that in some cases, parents and guardians can be super helpful for youth. But as I told you before, we also know a lot of youth are not telling their parents and guardians about their suicide risk. And so we thought it was really important in our version to just involve teens. I'm happy to chat more about that and pros and cons at the end. So, although a fun start, like any good research team, we wanted to know how teens actually would like our self-guided safety plan, whether it was actually a tool they would use when experiencing a suicide crisis, and whether they found it helpful. So, we designed a pilot study to test this adapted intervention. And we had two primary questions with this study. So, first, we wanted to know, do teenagers find our digital self-guided safety plan acceptable and useful? And second, we wanted to know how strong are the safety plan responses that teens are actually creating using a standardized coding system. And so we recruited teens online using social media, primarily Instagram advertisements, including the one pictured here. And interested teens were directed to complete a brief online screener to ensure they met our inclusion criteria, including that they were aged 13 to 17, that they had internet access, and that they had a past year history of suicidal thoughts and behaviors so that the intervention would actually be relevant for them. And our sample was pretty diverse. So, although majority white, the racial and ethnic diversity pretty much paralleled the race and ethnicity of teenagers in the US. Although I will say we had more multiracial participants and fewer Black participants compared to national rates in this age group. Additionally, our sample had really strong diversity across gender and sexual orientation, with most youth identifying as LGBTQIA in some capacity. I will note, though, that we had lower engagement among participants who were boys and men. So at baseline, we had participants answer a whole bunch of questions about demographics. They reported on their history of suicidal thoughts and behaviors, and then everybody completed our digital self-guided safety plan. We then used a few different metrics to assess acceptability of the plan, as well as their likelihood of using the card in the future. We then followed them up 1 month later, and we assessed, did you experience suicidal thoughts and behaviors or a suicidal crisis since baseline, whether or not participants used the card, reasons why they might not have used it, whether they found it helpful, and open-ended questions, sorry, not about safety, but about the card itself. I will say here, you'll notice we had a lot of attrition between baseline and follow-up. This is probably because we didn't pay as well as we should have. Participants were paid $5 for each time point because this was a pilot study and we didn't have grant funding. Luckily, though, there were no differences in race, gender, sexual orientation, or history of any suicidal thought or behavior between those who did part 1 versus part 2 of the study. However, participants who did both parts of the study were significantly older, 15.9 versus an average age of 15.6 who only did the baseline. Okay, so some key results that I want to share with you all today. So first of all, on average, participants reported that they were somewhat likely to use their final safety card in the future in the case of a suicide crisis. After completing our self-guided safety plan, all participants completed Dr. Schleider's program feedback scale, which assesses, participant feedback about the program on a variety of indices. And broadly, responses on this scale were pretty positive, reflecting an average score of 3.5 or above. And I will note that we had some really, really strong agreement with things like agreeing with the message and understanding the activity, both of which were really important for us, given that this is the first time that teens were doing this totally on their own. I won't go into too much detail here, but we also asked youth for open-ended feedback about what they liked and disliked about the card. And thematic coding of these responses revealed that teens found the activity helpful, that they found it easy to use. They felt that it was a safe space to share about suicidal thoughts and behaviors and to think through strategies. Many of them reported finding a wide range of new strategies that they were eager to try. They liked how personalized it was to them. They found it easy to follow, and they learned about a whole bunch of helpful resources they hadn't otherwise been familiar with. They also identified several areas of recommended change. So for example, some wanted to change some content of the card, wanting more individualized and more thorough solutions. Additionally, some felt that the formatting wasn't ideal. I will say with the initial testing, we had piped responses into the card that you saw right at the beginning, and the formatting really wasn't as strong as it should be. So that's something that we're working on. Some teens found the tone too clinical and formal and wanted something a little less formal. This was something we tried to do, but it was really helpful to hear that they didn't feel we were quite where we needed to be. And then others felt that there were things that weren't clear enough. So one really good example is there's this means restriction item on the safety plan where folks are supposed to think of ways to make their environment safe. And there was some confusion for them around, is this making their environment safe in general, making it cozy, reducing access to things like tools they could use to self-injure in non-suicidal ways, or was it specific to suicidal behaviors? So definitely some need to add even more clarity in future iterations. So 1 month later, we found that about 73 of the participants who completed the follow-up experienced suicidal thoughts or feeling unsafe and or urges to act on suicidal thoughts since baseline. And of these participants, about 32% reported using their safety card. And then among those who did use the safety card, they found it between very much and extremely helpful when they were in that crisis. Among those who didn't use the card, a variety of reasons were endorsed, but most commonly, they just didn't think it was going to be helpful for them in that moment. They didn't want to, and they didn't need to. I will say that about 11 said that they weren't sure how to find it, and that was a major bummer and something that we definitely want to address in future iterations. So to answer our original question, broadly, we did find support that teens who had experienced suicidal thoughts and behaviors in the past year found our self-guided safety plan acceptable and useful, and that they actually used it at similar rates to what's seen in studies of clinician-guided safety plans in both teens and adults, although we would obviously love those rates to be even higher. So now let's chat a bit about results from our second question. So the original safety planning intervention was created by Stanley and Brown, and they emphasized that suicide safety plans should be personalized and specific, and they should really make use of someone's own individual experiences and expertise so they can create a plan that's tailored and feasible for them. So ideally, optimal safety plans should have multiple responses for each step, and that they should be personalized and specific to them. In practice, studies of safety plan quality show that safety plans that are clinician guided vary greatly in quality with a wide range of completeness and specificity and personalization. Again, even when clinicians are guiding those plans. That said, we care about quality because we do have evidence from a number of studies that safety plan quality might be related to the effectiveness of this intervention. So for example, among US veterans, having a safety plan on file doesn't predict suicide-related outcomes, but having a more complete safety plan on file does in some studies. Another has found that quality in terms of personalization and specificity, but not degree of completeness, has predicted subsequent hospitalizations among high-risk veterans. And then finally, and most relevant to us, in a study of teenagers who are inpatients with a history of suicidal thoughts and behaviors, there's evidence that quality of safety plan is associated with lower likelihood of rehospitalization after discharge from the hospital. So in adapting our new safety planning intervention to this self-guided format, we felt it was important to know not just whether teens found it feasible and acceptable, but also we wanted to know if they could create high quality responses. And so this question was primarily led by Juno Pinder, who's an awesome graduate student on our team. And they had the idea to use an existing algorithm, the Safety Planning Intervention Scoring Algorithm, or SPISA, to look at the quality of safety plan responses. And briefly, the SPISA assesses quality on three domains, completeness, quality, and global impression. And so on the SPISA, completeness pretty much refers to the degree to which the card is completed. And there's a score for each individual step and for the overall card. And so in all cases, completeness refers to the number of non-zero or non-blank responses for that step. So if I did a safety plan and I gave 2 warning signs, but I left the third blank, I'd get a score of a 2 out of 3 for that step. Step quality scores show the average quality score of all coded responses for a given step. Quality here is determined both by the specificity of the response. So listening to music would get a lower score than listening to this specific song or this specific type of music, as well as personalization. This is kind of interesting because quality is averaged across all responses given for a step. So if I give 2 really great quality warning signs, but 1 poor one, that's going to decrease my quality score for that step. Again, there's a quality score for each individual step and for the overall plan. And then finally, there's a global impression score for the full safety card. And this is a 5-point subjective coder rating of the quality and completeness of the entire plan put together, ranging from poor to excellent. And so Juno led the efforts to code all of our safety cards, and they brought another team member on, and they achieved really, really excellent reliability. It was really impressive and exciting. I will say here, and we'll chat about this more at the end, that SPISA was initially created for clinician-guided adult safety plans. So we did have to make some minor modifications. Because of that, and because there was skepticism that teens would be able to do this well at all, we intentionally had coders interpret responses as conservatively as possible. So if anything seemed ambiguous or unclear, the lower of 2 scores was given. Okay, so on average, participants completed about 5.58 out of 6 safety card steps. In terms of completeness, warning signs and internal coping strategies were the most complete, and that helpful people, so people you can reach out to in a time of crisis, who you can go to support you, that was the least completed step, left blank by about 27% of participants. And in open-ended responses, some participants even said it felt really upsetting and invalidating that they didn't have those trusted people in their lives. In terms of quality, the total quality score was about a 10.5 out of a possible 18. The steps with the highest average quality were steps 4, so that helpful people, the ones who did complete it, actually were given quite high quality responses, probably because they were really specific and personalized to them, who they would reach out to. And another really high score for that was people and places for distraction. So what they might go do or who they might talk to when in a crisis, not necessarily to talk about their suicidal thoughts or urges, but instead to try to get them outside of that mindset. Those with the lowest quality were internal coping and making the environment safe, and that was because these usually just weren't specific enough. In terms of global impression, on average, plans got a satisfactory score of just about 3 out of 5. And 78% of plans in our study were rated as a 3 or higher for global impression. I will say that 3% were rated as poor, and no plans here were rated a 5 of excellent. You might not be surprised to learn that total completeness, quality, and global impression were all moderate to strongly correlated. Something that I found really excited is that contrary to concerns about whether youth can do these plans on their own, age actually was not significantly related to any of these quality indices, completeness, quality, or global impression, suggesting that 13 to 17-year-olds are similarly equipped to complete these safety plans on their own, which again, I find really exciting. So to answer our original question, it looks like teens actually do about as well as adults on these self-guided electronic safety plans. And so first and foremost, there is absolutely room for growth. And we have a lot of ideas building off of this study and some recent interviews with teens with lived experience on how we can be improving the safety card. That said, in studies that have used SPISA and clinician-guided adult safety plans, results are looking really similar. And that's even when we were being intentionally harsh with scoring. I think this is a really exciting outcome for us, as there was understandably a lot of doubt for folks in the suicide field about whether teens would be able to do this on their own, online and without involving a parent or a guardian. I want to reiterate, the SPISA, again, was created for adults and clinician-guided plans. So I do have some doubts about whether the SPISA system is, reflecting a final truth about the quality of our safety cards. And I'm happy to chat more about this at the end if folks are interested, but I have some other ideas for how we could be assessing quality as well. So we've been working to update images and language in our safety plan to incorporate youth feedback, both from this study and from those interviews with youth with lived experience of severe suicidal thoughts and behaviors. And we've nearly completed our updates. I'm happy to chat about some of the big changes that we've been thinking about. And we'll be launching our first large-scale RCT of the safety plan in adolescents using our self-guided safety plan pretty soon. So stay tuned for those results. I might pause here because it just seems like there might be some questions in the chat. And now might be a good time to answer questions before going to the next part of the presentation. Yeah, I'm very happy to send sheets. I assume that refers to the safety plan itself.
Yes.
Yeah, very happy to share.
I can field the questions, Kathryn,
Oh,
so you
cool.
don't
Thank
have
you.
to
That's
think
easier.
through them. A couple of questions that have come up. One is from Jeremy Eberly, a postdoc in our lab. What control or comparison groups do you think it would be helpful to include in future studies?
This is such a good question and something we've gone back and forth on. I always find it funny to talk about studies that haven't been launched. I'm just assuming folks in here aren't going to like scoop us and run the same study. But right now, what we're thinking about as a control group is a psychoeducation intervention about crisis resources. So we know there are a lot of myths and misunderstanding among youth about what crisis resources are available, who they'll be talking to, et cetera. And so we're going to work to try to correct some of those myths, similar to a control intervention that actually an active intervention that Dr. Schleider has used that we've kind of adapted here. And to also tell teens about peer-to-peer sources, because we've heard from a lot of them that they really don't want to be talking to adults. They want to talk to other teens who have gone through these things themselves. So our control intervention right now is planned to be psychoeducation about crisis resources. It's a little tricky because in some ways that is a step of the safety plan, but it's one step. And we think it's a really important step and one that represents a really common approach that's used by providers.
Yeah, it has a ton of face validity relevance for what would be normally offered in real world settings for sure. This is a question I imagine multiple people have. You mentioned parents and guardians did not have information about suicide ideation, et cetera, during the study. Can you describe more about the consent process and how you worked with parents and guardians to make them comfortable with this?
Yeah, we did not involve parents and guardians in this study. So I know people have a lot of feelings about this, but a lot of my research involves waiving requirements for parent and guardian consent. We do it for a lot of reasons. I'm really happy to chat about the ways that we do this and why we think that it's safe. But broadly in these studies, I think it's so important because we know from prior experimental research that when parents and guardians are involved, teens are less likely to participate at all. And if they participate, they're less likely to disclose suicidal thoughts and behaviors. So if we want to be reaching teens and getting them to accurately report, it can be really helpful to waive parent and guardian consent. This does mean we need additional safeguards. It has to be minimal risk studies, et cetera. And again, happy to chat more about that. But parents and guardians were not involved at all in this study.
Another question. Did you control for use of traditional safety plans during the study?
This
Were
is
they
something
allowed
that
or not
makes
allowed to
me
engage?
so mad that we didn't assess. We absolutely should have, and it's something we are going to assess in future studies. There are teens who referenced having done something like this in therapy, but they're like, it wasn't nearly as clear, or basically saying why they liked this more. So we know some teens had done it before just based on like open-ended feedback about the study, but we didn't assess it systematically, which was dumb.
I mean, hindsight is 2020 always.
That one feels obvious. I hate that feeling.
Um, oh, there are so many good questions. You mentioned access to resources was improved. Were these resources personalized? Could you describe what you offered to participants?
Yeah. So in general, with a traditional safety plan, there's this thing where you typically ask them to think about like who their therapist is and how they'll be able to contact them in a crisis. And yet not all of our teens were in therapy. And on top of that, we know that many therapists actually are not willing to be contacted when teens are in crisis at any time, unless they're seeking very specific types of therapy. So we also basically provided a whole bunch, like maybe more than we should have, a whole bunch of different crisis resources. The most commonly selected actually was the Trevor Project, probably because our sample was majority queer, but we provided like brief mini psychoeducation and links to probably 10 different crisis related resources. And that's actually something that we're streamlining in the next iteration as well, because there's only 3 slots and people selected on average of 5 of these different crisis resources. So we're thinking a little bit about how can we not make the card really ugly, but also make sure that they're able to access easily all of these different crisis resources that they're interested in trying out.
Awesome. Before I keep going, are there more slides you'd like to get through, or should we keep going with questions?
The other part of my presentation has to do more with that parent education and feedback piece. So since this is the primary focus of the talk, I kind of defer to you if it's better for me to answer all of these now because it's about what I just chatted about.
Yeah,
Or if
maybe a couple more that are directly relevant, and then we can keep going.
okay. And then if
Um,
after this people have questions, feel free to email me as well.
yeah. How would you imagine disseminating this to teens in need? As an
Hmm.
how are you? How is it already being disseminated to teens in need?
Yeah, so we have been disseminating it in a bunch of different ways. So, first of all, the current version of it is actually freely available on my website. And something that I have been doing, especially with other youth suicide researchers, is just talking about it in talks like this, telling people to feel free to use it. It's also been adapted and used by folks in Children's Hospital in Arizona. And in a few other specific clinics as well as just like an easy opportunity to not necessarily have to face training everybody in how to administer these kinds of interventions and instead having an opportunity to have youth complete this in a format that has been shown to produce relatively strong quality safety plans. Long term, I have a lot of additional ideas about how we can disseminate it. I have another partnership with the same collective where we're going to be thinking about disseminating this as well. But because right now we're still kind of iterating and wanting to make it better, I'm really reticent to like send it far and wide when I think that there are actually some small changes that we can make that'll make this even better. So we are disseminating it and I want to be cautious about it because I think we can do better.
Awesome. Very exciting. Can you tell us more about the recruitment strategy and why TikTok wasn't used? I'm a young person myself, and I'm seeing a major surge in TikTok consumption.
Yeah, TikTok would be great. And we have tried to use TikTok for some studies. There are a lot of limitations to it. They are pretty reticent to allow you to post advertisements specifically for individual studies, especially related to mental health and youth. So that's probably the biggest barrier that's really, really difficult to get around. Some of those restrictions actually are now being applied to Instagram, Facebook, and other social medias as well as we're trying to protect youth, which is really important and a huge part of the conversation about teens being online. And a major bummer because I feel like we're trying to disseminate interventions and it's kind of disrupting that pathway. There are other ways to advertise on TikTok by like creating your own page and being clever and building a following. And you might think that I seem like really dynamic and cool, but unfortunately, I am not. And I struggle to create a kind of TikTok that has a big following and recruits really widely. We've involved youth in that effort and we've gotten some movement, but again, because you're not able to do the paid advertisements there for this kind of work, it just has not worked as well for us. It would be a more representative sample if we could do it well, and there might be a way to do it, but it's tricky.
It is truly tricky with TikTok. Lots of barriers. Another question. Did you ask folks at follow up who ended up using the safety plan what brought them to use it?
Yes, we did. We asked both what brought them to use it and then also like things they liked about using it and didn't like about using it. And I didn't have too much time for that. But the most common things that brought them to using it were experiencing severe suicidal thoughts and or urges.
And another question, how do you handle the possibility that youth will disclose specific urgent suicidal plans and pretext responses?
Yeah. So one thing that we do is we are really clear with participants about what we can and cannot do in the moment in terms of intervention. And so with this study in particular, we actually the most recent period of suicide related thoughts and behaviors we asked about was over the follow-up 1 month. We did not ask about things like past week, past day, or current. all of which are necessary for helping us to understand current risk. And there's still the possibility that people will type it in to open text responses, but I haven't had that yet. If that did happen, we absolutely would want to reach out to them over email or remind them of resources, things like that. And we can't control, what they do and don't share with us. But we don't have a ton of ways to contact them or find them by design to maximize their willingness to participate in this type of study.
Awesome. One more question, and then maybe we can keep going.
Sounds
Um,
great.
if many teens who did not use their safety plan felt like it wouldn't be helpful, are there efforts to involve youth in providing qualitative insights in what they think would be more helpful or what has been helpful in the past?
Yes. This is a fantastic question. So first of all, even within that study, we had open-ended questions asking this type of thing. And then we also did qualitative interviews more recently with people who had experienced more recent suicide-related thoughts and crises. And so from that, we've learned a lot of things about basically what's gotten in the way of youth using the card and the past. And that's part of how we're making updates now is based on their direct feedback about things they did and didn't like about the card, trying to maximize the things that they liked and reduce the things that they didn't. I will say a lot of them brought up too, like, I want this to be easier to access. Let's brainstorm ways to help youth to just know exactly where to find it, for example. And let's also help with some of the questions that feel really invalidating in the moment to those youth who don't have, those trusted people in their lives, where it can actually kind of hurt to give that reminder, like, oh, I have nobody that I can go to in a crisis. And this card is just reminding me of that. So how can we think about more creative ways to help direct youth to find trusted people, ideally adults, but that's not always possible, and or to make that step a little bit more inclusive of folks who might be more isolated in this moment, which is often inclusive of people of going through a suicide crisis, who might be in fights with or having major issues with people who previously had been those folks that they could go to for support. Okay. People are more than welcome to send additional questions here, but for now, I do want to chat a little bit about other ways to overcome barriers to suicide prevention care. And so I want to switch things up and chat about another project that I'm working on that seeks to address youth suicide through intervening on parents and guardians. And unfortunately, as I've said before in this presentation, we know that most parents are unaware of their child's suicide risk. So we have meta-analytic evidence that less than 50% of people disclose their suicide ideation and attempts to anybody. And age is not a moderator of this effect, suggesting youth report similarly low levels of direct disclosure. And so with my collaborators, doctors Alex Vettis and Taylor Burke, we surveyed two separate samples of treatment-seeking adolescents as well as hospitalized adolescents. And we actually found really similar rates of disclosure, even in these samples overall, with even lower rates of disclosure specifically to parents and guardians. And in a lot of ways, these low rates of disclosure are a major problem because if parents and guardians don't directly or indirectly learn about their child's suicide risk, they can't support them in, understanding their level of risk, getting them connected to appropriate care, making their environment safe, et cetera. And on the whole, we tend to think that it's a really positive thing for all of these reasons for parents and guardians to know that their child might be at risk of suicide. Because again, it's giving parents and guardians an opportunity to support their children and mitigate risk. And yet, we also know that nobody here is really trained, unless they are, a clinical psychologist or in a related field, with how to manage it if they find out that someone in their life or someone they love is at risk for suicide. And so if you feel safe to do so, I'd love for folks in here to take a moment to either remember a time that they learned that a loved one was at risk for suicide, or to imagine that they learned that someone specific that they loved was at risk for suicide. And I want you to really think about the thoughts and emotions that might be going through your mind, that panic that you might feel if the risk seems imminent, and the eagerness to do anything in your power to keep them safe. Or alternatively, it might make no sense to you. Maybe that loved one is a really happy person who has everything they could possibly want or need, and it's just really hard to understand how or why they might be at risk for suicide. And within that, I think it's just so easy to assume that parents are going to respond effectively when they find out about suicide risk in their kid. And yet, It's really hard when parents find out in the moment that their kid might be at risk, and regulating their own emotions and problem solving effectively and helping to validate their kid can all be really, really difficult. And so, reflecting this difficulty, my colleagues and I have conducted studies with treatment seeking and hospitalized youth to better understand their perspective on what it's like when parents and guardians learn about their suicide risk. And some youth report really positive experiences, like those listed here, where they receive great emotional support and validation and curiosity from their parents and practical help. But most youth report mixed and negative experiences marked by parents and guardians having really, really strong and scary emotional reactions that teens find aversive, that they feel really invalidated by parents not understanding or saying that there's no way you're suicidal, or they end up feeling punished because parents restrict access to people, places, and activities. In many cases, they say that parents either avoid directly asking about suicide because they don't feel comfortable talking about it, or they seem visibly uncomfortable talking about it, making it so teens don't feel like parents are safe people to talk to about their suicide risk. And critically, when these initial disclosures don't go well, youth say that they're significantly less likely to disclose to their parents and guardians again in the future, making this a really high stakes situation. And those first experiences of direct or even accidental disclosure being really, really important ones for youth trust that parents and guardians can and are equipped to help support them. And so this led my colleagues and I to want to know both, how do parents feel that they're reacting when they're first learning about child suicide risk? And also, what do they want to learn? What do they need to learn or feel that would help them better support their children in cases of learning about child suicide risk? And so it turns out it's pretty challenging to get access to parents who have just recently learned about their child's potential suicide risk. And so that brought us to collaborate with industry. And so, as I'm sure most of you are well aware, there is growing parent concern about skyrocketing youth social media use and mental health problems. And there's been a major proliferation of subscription based parental monitoring apps, including those listed here, that are tracking children's digital engagement and meant to safeguard children online. As of 2020, 72% of parents reported using some parental control tools to oversee and limit aspects of their children's smartphone use. And then the parent digital monitoring app market is huge and growing. It's currently estimated at $985 million, and experts anticipate exponential growth over the next decade, suggesting many, many parents are interested in and already using these kinds of apps. And so, as you might guess, researchers are really focused on understanding how can we leverage smartphone data to understand suicide risk and potentially intervene. Industry is also really interested in this, and as they do, they've moved really quickly compared to researchers. A growing number of these apps are now monitoring children's digital traces to identify when suicide-related content is shared or accessed, and to promptly alert parents to their potential suicide risk. This technology definitely has promise. And I will say, in my experience playing around with these apps, testing them, et cetera, it's a pretty low bar for indicating that somebody might be at risk for suicide. And so it's not uncommon for parents to receive something called the suicide safety alert or something similar, where they learn that their child might be at risk for suicide. And they have to not only figure out, is this a valid alert? Are they actually at risk for suicide? They said, I'm going to kill myself after failing a test, to a friend in a text message. Did they actually want to kill themselves? Are they just using that colloquial and problematic language that youth always or often use? So they first have to determine, is it a real risk? And then they also have to figure out, how do I help support my child? And so, alongside one of these apps, we have done some initial surveying of parents to look at broad emotional reactions to learning about child suicide risk, how they're managing their child suicide risk, and then also just seeing, like, are they interested in intervention? What kinds of things would be helpful, et cetera. And then after getting all of that feedback, we have decided to move forward with creating a brief single session intervention where we're going to be providing a whole bunch of psychoeducation about youth suicide, as well as providing some information about parent emotion regulation, about how to validate kids, about how to engage in suicide-specific monitoring and lethal means restrictions in ways that aren't punitive, etc. And we're really excited to be testing this in a study of both parents and teens and preteens to understand and see whether or not our intervention is able to both educate parents appropriately for how to respond to risk and also whether that's related to child suicidal thoughts over time. So happy to chat about that more if folks are interested. But first, I just want to say a thank you to the Fox Lab team, including a special shout out to Juno Pinder, who led that second question I told you all about. And let's also thank the many collaborators I chatted about today, including Jessica Schleider, Taylor Burke, Alex Bettis, and Shirley Wang. Okay, that's all I have. So I'm happy to answer more questions at this point. And thank you all for listening, especially on a stressful and probably chaotic day for everyone.
Kathryn, thank you so much. That was so fantastic. And the future directions you mentioned are incredibly exciting and needed. I'm so glad that you're at the helm of pursuing this work. Let's see, in terms of additional questions, we do have about 10 minutes. If folks want to enter additional questions into the Q&A box, now is your chance. Otherwise, Kathryn, you've answered all possible questions in this entire domain of research. Congratulations.
Thank you. I'll put that on my CV.
Yeah, as you should.
Mm-hmm.
Front and center. Okay, one more question is coming in, a couple more. How are you measuring parent quality of response to adolescent suicidality in the study you just shared?
Ooh, quality response is tricky. So we do assess things like what are their actual internal emotional reactions. We're also going to be measuring child perceptions of parents' emotional reactions, as well as steps that parents are actually taking. And so pending their own reports of child suicide risk, it's really helpful to know what are they actually doing? Are they asking their kid directly whether or not they're having suicidal thoughts and behaviors? Are they engaging in some kind of means restriction, talking through, access to different kinds of therapists if they're not already connected, et cetera? And then again, looking at kids' perceptions of those experiences, whether they're feeling validated in the moment by parents, whether they feel their parents understood their level of risk, whether they did actually ask directly, all of those kinds of things.
Super interesting. Another question coming in from Benji Cavalazzi, who's another one of the awesome postdocs in our lab. Can you talk more about the purpose of collaborating with these companies with respect to parent alerts? Personally, I'm also interested in hearing your thoughts about these companies in in general. And do you see collaborating with them as a way of mitigating possible risks that they might otherwise pose?
Yeah, basically, we know these apps are out there and that they are giving these suicide safety alerts right now. And then we also know that they're not providing much, if any, information to parents for how to manage learning that their child might be at risk for suicide. Sometimes there's like a one pager, like, have you heard of 988? And like, okay, bye. And as we chatted about before, from parents' perspectives, these are really, really scary, difficult alerts to get. And determining child risk level and actually thinking about how to respond is all really difficult. So we see this partnership as important because we know these are gaining popularity. And so I think it's a really relevant intervention point because parents are going to be finding out more and more about child suicide risk than before because of access to these kinds of apps and information. And it's just a pathway to really quickly disseminate and test intervention. I don't necessarily think it's the best way to do it, but it's one of the easiest kind of ways in to reach a lot of parents really quickly. I will say I have hesitation, really, really strong hesitation about these apps. Some of the apps require child knowledge that the parent is using them. Some of them don't. I think that there are major problems when parents are not clear and guardians aren't clear with kiddos that they're being monitored. And to be in this study, they have to let their child know. Like they cannot be in the study unless their child is aware, obviously, because the kid's going to be in the study. On top of that, I think it's great that we want to alert parents that their child might be at risk for suicide. And I wish we were at a state of affairs when these apps were doing a better job. at detecting suicide risk before putting these alerts in front of parents. And then broadly, I think a lot of discussion needs to happen between parents and children about trust and how to use social media and texting, et cetera, responsibly. And this feels like a band-aid, not a fix. That's really easy to be like, okay, I'm monitoring it, everything is fine, when really that's I think only a really small piece of the puzzle. I think these are really, really tempting to use and seductive for parents to subscribe to. And I'm not sure it's solving the problem that people think it's solving. We know a lot of kids learn how to avoid getting detected in algorithms, and how to get around these things. They're very wise and savvy, more so than we are on the internet. And so I think, the more these proliferate, the more creativity from youth is going to come about to prevent them from being as effective as parents think they are.
Especially if they're fearful of what might happen if they trigger the algorithm and the response and what happens next isn't clear, as you shared at the beginning. And
Exactly.
I do feel like this pattern is also reflective of broader trends in digital mental health, where state governments or departments of education will roll out a new digital mental health
Yeah,
tool simply to say that they're addressing the problem, rather than taking the time needed to really investigate whether it's work out of an implementation and evaluation plan that's safe for everyone.
exactly.
A couple more questions. I imagine the parent guardian's bandwidth is a huge factor in how they respond to their child's STBs. Is there priority in addressing parent stressors for these particular families?
Yes. So that's a big thing that we heard from parents directly. Actually, like one of the biggest barriers to participating in intervention to begin with is like they are so overstretched already, especially teen parents that are involved in millions and millions of things as well as their own lives and work, et cetera. And so the piece on parent emotion regulation will also include how to find the people in their lives, for example, that are support people for them, emotion regulation strategies for stressors in their own lives, et cetera, with an eye towards you can't help support your child's emotions if you're not able to support your own.
And final question, I think before we wrap for today, for the study on parents' needs, perceptions, and emotional reactions of suicidality among their children, are there specific considerations to cultural backgrounds and immigration or generational status of the parents or children?
This is a great question. So we're actually going to be doing a lot of piloting in an intentionally diverse sample of parents before finalizing the intervention. And so these are all things that we're thinking about. We've already started to create content specifically for racial and ethnic minorities, as well as for LGBTQIA parents and or youth, and consideration for those specific communities. But I think those pieces about immigration stress are huge here, especially when we're considering systems involvement, et cetera. And that's definitely something we should keep an eye towards as well.
100%. Well, thank you so much. On behalf of everybody attending right now, we're so grateful for you sharing your knowledge and expertise in this area. Really so excited to follow these new directions that you're pursuing. And thank you so much for taking the time to be with us today.
Thanks so much for being here, everybody. And I hope that your days are as low stress as possible and that you have your own plans for distraction and coping to get through the next 24 to 48 to 4 years hours.
Thank you.